So schizophrenia is a very long journey, starting from birth till death. It continues, and within that time, something like a hacker comes and it distorts the neurons, the synapses, and it distorts the communication line, and also in an adverse manner, it has an impact on the individual's life. Against this hacker, the scientific people are just trying to come up with some solutions, and also a revolutionary finding was happened 75 years ago with the invention of chlorpheniramine, and also the treatment policy has changed since then, and also the open door policy has started, and in their natural environments the patients have started to be treated, and within this time 1 or 2 doses of medication was necessary, but in the upcoming time some new treatment came to the fore, and also instead of using 1 or 2 doses per day, every 180 days, once in every 180 days, a new policy has started. So the medication that brings us some advantages because we use only once in every 180 days. And also the first speaker will be mine. My name is Dr. Özcan Uzun from Gülhane Psychiatry department I come from, and I'm going to talk about the 1 month and 3 months of medicines. I'd like to share my experience with you, and following that, Mesut Yıldız will talk about a paliperidone method. He's going to share his experience with you. So regarding the long-lasting antipsychotics, what we say? So in its nature, schizophrenia, it starts before birth, and also the first symptoms start during the 20s, and at that time a very destructive process starts with some new seizures, and also it really drops a sign in the brain. So what about the relapses and the frequency of the relapses in schizophrenia? As you all know, and nearly 80% of all the findings and patients have more than one seizure. Why it happens? Why the patients have those seizures? So if you find an answer to that question, the most important thing here is that there might be some adaptation problems, and as well as that depression, stress, substance use, and the medications used, and also the long-lasting antipsychotics lack of use, and there is some adaptation problems with the treatment in the very first place, and in the final bottom there is a long-lasting misuse or a lack of use of the antipsychotics, and this slide actually gives us the answer where the problems comes from and also the course of that problem. So how does it happen? I mean, the relapses just puts the sign in the brain, and also the neurons, and also the synapses loss it causes, and also there's a thinning of cortical, and also there are some distortions in the brain. So there's a very interesting vicious circle here. So the relapse causing these kind of things, and also it's just has the new floor for some new vicious circle. And also there's stress, neuroinflammation, oxidative stress, and neuronal damage, and also dopamine sensitization. These also causes this psychotic relapse, and also after this happens it also causes some bigger problems. So this is such a vicious circle. So isn't there a treatment that will also distort this vicious circle? So I've just mentioned them. I do not want to underline them once again. So what happens when the patients have relapse? It already happens. and also the response to treatment is also delayed, and also for a longer time in order to get a response from the treatment, some longer period of treatment, and with higher doses of antipsychotics are being used, and the combinations of them are also increasing. So in many years, one of the things that we face in our clinics, the patients with schizophrenia, with treatment the patient can feel himself really much better, but because of a reason he might or she might have a seizure, and also in order to recover from that, so it takes a lot of years to recover. And also a patient relative just said that, so before we have the experience to recover much easier, but he just tried to make me feel that we cannot do our job well, but they do not know that after every single seizure the things are getting more challenging and the resistance increasing, and that's why we are required to use higher doses of medications and combined treatment. But in spite of applying all these combined treatments, we unfortunately cannot have the necessary treatment or recovery in the end, and it also causes some higher costs together with the other adverse side effects. So what happens in these relapsing? So there is a brain damage, as you say, after every single seizure. Within 1 year, the median value is that 1.5 neurons loss happens annually, and also this is just a burden on every single individual having or going through this process, because there's a brain damage here, and unfortunately they cannot regain what has been lost. And also the best description of what we see here is that in the first seizure, the symptomatic remission is 52%, and also the recovery rate is 20%. So what is it related? So is it with the short and untreated periods? So independently they are correlated with that. But as the number of seizures increases, as we cannot prevent these seizures, this optimistic table turns into a 3% of recovery. And this 3% is even an optimistic figure. So what determines that recovery? What is the most important independent variant here is that the analysis showed that the adaptation to treatment is so important. If there is an adaptation to treatment, then there is a recovery. There are no newer relapses. But if there is no adaptation with the treatment, unfortunately, as I've just said, these important stories start. So in identifying prognosis, of course, these seizures prevention is so important in the very first place. This is a very critical duty of ours. So I like this remark, especially in the first seizure. They say that in the first seizure, the most important goal is not to treat the symptoms of the patient, but to make the patient feel more secure. So the patient should feel himself secure, and then he or she will not have relapses, because whenever the patient has relapses, then the trust in that treatment is distorted significantly. So, for example, I gotten treated for many years, but it doesn't work. Lots of patients say it is. So of course there's a lack of motivation to start a new treatment. That's the patient's perspective. So together with treating the patients, also preventing the newer seizures is also another important factor to motivate the patient. So how we can prevent relapses, these seizures, what we have in our hand, and of course the adaptation of the patient to treatment, and also in our hand the most important tool is that the long-lasting antipsychotics. That's also another important topic is that, so the continuous monitoring is also another important thing. So what we mean here is that, but beyond that, I like to say that, so the patient, whenever he goes, to the clinic, he should see the same physician. So if the patient sees different physicians whenever he goes, it's problematic. But the therapeutic cooperation between the patient and the physician is so important in the treatment. So I'm been following up many different patients, and they really like me a lot. And also, for example, the person who has read the medicine in English, he has just dropped out for 3 years, and then we came together and we started our treatment. And he was very fond of me, and when I said to him that he needed to continue his school in spite of his fears, his concerns, he continued going to school every day, and he was in tears all the time, but he really did not make me disappointed. And the result was that after a 3 year of interval, he was just graduated in the honorary list. And that's the result that we see here. So I said that the relationship between the patient and the physician might be even more important than the medications. Trusting the doctor is so important. For example, when the patient goes to the internal medicine department, so he's told to be prescribed such medicines and so on. But if you would like to continue with the cooperation, you need to have a very robust interaction with the patient. But the lack of adaptation to treatment is the most important, is the biggest problem. So as a preventive measure, there must be adaptation to treatment. So what about the patients? Do they conform to the principles of the treatment? And also before the 18 months, they just give up on using the medication. 74% of the patients did the same thing. And also the median time for discontinuing the medicine is 6 months. So the medications are the solution, but because of some different reasons, unfortunately, some patients discontinue using their medications, and it causes the relapses, and 5 times more possibility of having relapses takes place as a result of that. So what about the long-lasting effect? So what about the second measure is the long-lasting antipsychotics use. So from 1 or 2 doses of medicine per day to 2 doses of medicine per year we have come. So as a relative of the patient has just said, they said that there's a vaccine for schizophrenia. That's a very important thing, that you all know that if the patients are not motivated or if they are not adapted enough, then they become really not resistant. And it takes 2 hours to take the medicine for these patients, really. And of course, our duty is not to provide comfort for the family. Our duty is to treat the patient. But that cannot be ignored. So these long-lasting antipsychotics, they're protective, okay? And what about the real-world studies? Ibrahim is with us, and in a study that we did together with Ibrahim, there are 2 protective factors: the use of long-lasting antipsychotics, and also with earlier relapse in patients with schizophrenia, there are also some demographic factors as well. And in the real world outcomes, again, there is a 30,000 case study in Sweden, and we can see again the important use of antipsychotics here, clozapine, and also another long-lasting antipsychotics in order to prevent relapses. These are the most effective ways of treatment. And paliperidone palmitate family, what advantages they bring to us? So in the real world randomized analysis, so when there is a comparative study of the oral antipsychotics compared to oral antipsychotics, there are fewer inpatients in the long-lasting peripeloton components used. So between 1 month and 3 months, there are two effective, two preparates comparison. And what we have here as the affecting time increases, the percentage of relapses decreases. And it shows also more adaptation to treatment. And how does it happen? So all the skill or the blessing come from the long-lasting effect. Just because of the long-lasting effect association, or are there also pharmacokinetic stability? Does it also contribute? Yes, the answer, they also contribute to this positive impact. How does it make this? So there's an early therapeutic level of loading. So this is also a feature that we do not see in the other long-lasting impact. Let's have a look at them one by one. So what happens here? On the 6th day, the plasma levels need to be attained. So the oral loading dose is not necessary at the very beginning, and in a very short time, the targeted plasma levels can be attained. So of course the response to the treatment, as you see here, on the 8th day it starts. And when you check the pulse scores on the 8th day, there are meaningful increase. That's a perfect thing. And it also brings us some other advantages. The response to the early treatment assures the patient to stay with the treatment. So if we can just prepare this response, that's so important. And also one of the goals of the treatment is to make patient feel secure. So the patient trusts the treatment after a while and stays with the course of the treatment. And we can just predict that one by using this way. And another important thing is, so in a consistent way, so it provides dopamine receptor blockage. It's done in a stable manner. For that reason, this short-term shortcomings or blockages in the receptors do not start to pose problems. Does it happen normally? Yes. Within or between 1 to 10 days if they discontinue the medication. So this is also a 2 times risk factor for the patient. So they studied on that and they found that. But as you see here in polypenoids, the stable consistency, because there is a B2 blockage receptor, we do not face such a risk. And in another mechanism, on the very first day the release starts and it just lasts for 4 months. Normally it's a 1 month dose, but up to 4 months there's a release of the medication. And also the protective side continues up to 4 months. So, and it might also continue up to 18 months, and also 1.5 years there might be the protective effect of this 1.5 dose. Another important thing is that in deltoid practices there is a faster Gmax However, in aldehyde practice, the D2 process reducing from 140 days to 95 days. So there is a rapid blood level or circulation, but the but it takes shorter time to have that. And what message does it give to us? If we want to have a rapid reaction, we need to apply DEL to it. But if you want to have a long-lasting effect, clitoral practice you need to continue with. From time to time, we've seen patients, and they said that in the last 10 days, things are getting more complicated, the patients say. And in the last 10 days, for example, the first treatment need might arise. So at that time, we say we should prefer glutathione for a longer lasting effect.
And so what did we say here? We said that the effective period for 3 months has a protective effect for 6 months, and studies show us that after discontinuing the treatment, the medication, for the 3 months to relapse, the duration is over 1 year. So there's a long-term protection offered. But for 1 month, that is half that. So what does this mean? This means that the longer the half-life, the duration to relapse is longer. So the longer the half-life protects from relapse further. These are the pharmacokinetic differences. So I've briefly introduced those. So it's not just a long-term effect that is the case here. It's also the T2 receptor, and together with that, the rapid onset of effects, together with the half-life being prolonged, these all provide us with longer-term protection and pharmacokinetic stability. And as a result, these are advantages that appear for us. So what can we say here? In the treatment of schizophrenia, it's a very important target to prevent relapse. So why is this important? Because every relapse leads to resistance to treatment and also results in a lack of effects, and also to brain damage, and also we also have because of a low reduced relapse risk, and it also offers us neurobiological stability. So long-lasting antipsychotics give us these benefits. And with this, I'm wrapping up. Thank you. What are we doing with the duration, Mr. Tuja? We've wrapped up early, so we have time. If we have time, so while we're all here, if you have any questions, if you have anything to contribute, let's talk together, and then I will be leaving the floor to Mr. Tuja. Thank you very much for your presentation. These depot antipsychotics, their use in children and adolescents, I'm wondering about that. For example, patients with developmental issues, if the family is chaotic, etc., can we think of it on the front line, essentially? Let's say we have a 6-month PPM treatment. Depot antipsychotic versus oral antipsychotics. Is there a negative impact, a negative effect here in this regard? When we consider it, yeah, we're talking about the positive effects all the time, but when we consider the negatives as well, can you add anything about that? Thank you. Okay, so there are 2 matters here. The diagnosis is very important, and the second thing is the condition of the brain is very important as well. So what are we saying here? If the person has soft neurological symptoms, so in the anatomic structure of the brain, if there is a problem, for me, long-term usage should be avoided. Why? Because these structural problems in the brain lead to other risks. So we need to avoid using the long-acting, long-lasting. But if there is no problem, then for children, my own personal opinion, I'm not talking based on literature here, by the way, I think it's more suitable. And the reason for this is, and the basis for this thought is that you have a stable blood level that is achieved here. So, in other words, we know that when we talk about side effects, well, let me put it this way, actually. Even if it's not the general rule, for antipsychotic effects, 60-65%, above 60-65, or below 70-75, that's the value we're seeking here. Why do we not look for over 70-75%? Because above 70-75, then the side effects appear after 80-85%, but above 70-75%, the dopaminergic system is blocked significantly. So depressive effects start to appear here. And as a result, that stability, being able to achieve that stability without leading to these highs, so a high above 75-85%, which is also not going to lead to a drop below 65%, which this occurs under 65. We say 65% blockage, but that's an average. So what does this mean? That means that it drops below and also rises above as well. So that stability in terms of effect and side effect, as it's going to achieve a stable blood level, this is actually advantageous. And as a result, I do recommend it, and it can be used. But of course, I'm not a pediatric psychiatrist, and we do need to look at literature in this regard. But if we think of the logic, and we can see that it has a protective effect in terms of both effect and side effect. And as a result, I can say that it can be used. And there's a second important point here for PPM, which is the physiologic dopaminergic effects not being affected. When you don't affect this, the cutoff value comes to mind. The cutoff is lower. It goes to the dopamine receptor. It sticks to it, and it just won't leave it. And this disrupts the impact of physiologic. We know for paraperidone that it's not that aggressive in its adherence to the T2 receptors. So it does not disrupt it to the point of not detaching. This is another advantage we're not talking about, and for this reason it can also be considered for pediatric patients. The physiologic dopaminergic effects need to be considered here. Thank you very much. Do we have any other questions or contributions? Really, I would like to thank you. It's been a great presentation. Yeah, we do have a fear that when we have long-acting, we use higher doses. But have you seen like any acute, like catatonia? Is the risk there when we're injecting a longer-acting, higher doses, like catatonia? Any risk or any fatal? In terms of neuropleptic syndromes, I haven't come across any cases here, to be honest. But what have I faced? Tardive dyskinesia and dyskinesia. I have faced this. I've come across this. And for this not to happen when initiating treatment, as I said earlier, the patient needs to be selected well and needs to be routinely followed, at least in terms of soft neurological symptoms. They must not exist. That is a significant risk factor. But catatonia, malignant syndromes, I haven't. But I have come across, like I said, the kinesia symptoms. I had a patient, for example, that I was even messaging before we came in, a long-term classic psychotic was used, and it's the most resistant tardive dystonia patient I've ever come across. We give clozapine, and the clozapine dosage, I lower it, then psychotic symptoms appear, I increase it, and then the dystonia appears. And there's nothing we haven't done. There's nothing left that we haven't done. We've brought medications from abroad. We brought medication from abroad as well. We've tried everything. But unfortunately, in this patient, the dystonia we have not been able to prevent. Yes, it passes. And so clozapine does have a treatment effect, but they're so sensitive to clozapine that when we raise the dosage a little bit, then the symptoms appear, and when we lower it, then the psychotic symptoms appear. That's the matter that we're dealing with. So we need to be careful when using it. We should not be sharing paracetamol. It's not something we should be using on every patient.
Profesör Doktor Ayten Erdoğan, çocuk ve ergenlerle daha çok çalışıyorum ve şimdiye kadar Tribekta'yı ve Zeplion kullanımı çok kullanıyorum ben, özellikle özelde de. Hatta Bakırköy'e de gönderiyorum, onlarla da birlikte tecrübe arttıralım diye. Çok da etkili, çok memnunuz. Ama şöyle bir şey var, acaba bizim yaş grubuna özgü mü? Yoksa bütün herkes için mi? Örneğin Tribekta'yı 2,5 ayda yapmamız gerekiyor. 3 ayı kesinlikle bekleyemiyoruz. Hastalarımızın klinik durumundan. Yine Zeplion'u işte 25 gün, bir ay asla bulamıyorduk. Şimdiki endişem geçtik 6 ayla. Acaba bu sefer 5 ayda mı olacağız? Yani 6 ayı bulamayacağız. Bu konuda ne dersiniz?
Efendim bu konuda Mesut Hocam 6 aylık için bir şeyler söyleyecektir diye düşünüyorum. Ama hocam bu sorun hakikaten klasik. Hani son 10 gün, işte son bir hafta sıkıntı yaşıyoruz diye. Ve hasta yakınları çok. Onun için işte ilk tercih olarak belki nedir? Gluteal uygulama. Şurada neredeydi o? Tabii şunlara dikkat etmek lazım. Yaş, cinsiyet, vücut kitle indeksi, kreatin klirensi, bunlar ilacın hedef düzeye ulaşmasındaki süreyi etkilediği kadar vücutta ne kadar kalacağını da etkileyen şeyler hakikaten. Dolayısıyla onlara dikkat etmek gerekiyor ama bu son zaman, işte son 10 günde, son bir haftada, belki işte 6 aylıkta, son bir ayda etkisizlik konusu en ciddi problem. Maalesef ki hani ödeme sisteminde ille de 3 ay olsun, ille de 1 ay olsun, 2 ay da bu hastanın durumu 2 ayı gerektiriyor desek de bu konuyu aşılamıyor maalesef. 2 ay uygulamaları yurt dışında var galiba bildiğim kadarıyla. Evet, firmadan arkadaşlar daha iyi bilir. Bu sebepten dolayı bu 2 ayda bir uygulamaları şeklinde, hani 3 ay değil de 2 ay yapalım şeklinde uygulamalar var. Ama bizde henüz yok. Umarız olur ve bu konudaki sıkıntı aşılmış olur. Buyurun hanımefendi.
Teşekkür ederim hocam sunumunuz için. Ben Kocaeli Üniversitesi'nde çocuk psikiyatrisi asistanıyım. Benim sorum da şu olacaktı. Oral paliperidonu tolere ettiğini bildiğimiz bir hastada direkt 3 aylık enjeksiyona geçebilir miyiz? Yoksa enjeksiyon için acaba öncelikle 1 ayı deneyelim, 1 aylık enjeksiyonu tolere edebiliyor mu diye bakıp sonra mı geçmek daha faydalı olur?
Evet. Orali tolere eden enjektabulu haydi tolere eder. Çünkü enjektabul uzun etkili de yan etkiyi daha az bekliyor stabil bir kan düzeyi olduğu için. Ama sistem izin vermiyor. Diyor ki önce mutlaka bir aylık denemen olacak. Yoksa pratikte düşündüğümüzde evet hiç zaman kaybetmeye gerek yok. Uygulanabilir. Dediğim gibi oralı tolere eden onu haydi tolere eder. Ama ödeme sistemi buna izin vermiyor.
Teşekkür ederim.
Rica ederim. Evet arkadaşlar sonra devam edebiliriz. Mesut hocamı daha çok bekletmeyelim. İşte 6 aylık paliperidonla ilgili durum nedir? Mesut hocam sizlerle bilgileri paylaşacak.
Teşekkürler hocam.